Hello guys, I'm Dr. Lee. Today I'm going to talk about a case of recurrent patella dislocation. Especially today I have a patient interview video. She will tell you how she felt when her patella was dislocated.
슬개골이 빠지면 어떤 느낌이 나나요?
근데 저도 너무 그게 순간적이어가지고 턱이나 어깨처럼 다시 이렇게 끼워야 되는 건 아니고 빠졌다 들어가거든요. 근데 그 순간에 항상 넘어져요. 그 넘어진 순간에 그 자리에 이렇게 앉아서 조금 시간이 있다가 일어나서 이렇게 해야 되거든요. 근데 제가 그 마지막으로 수술하기 전에 넘어졌을 때가 그 주차장이었는데 이제 거기서 이렇게 일하러 들어가다가 넘어졌는데 차가 오는데 못 도망가게 된 거예요. 넘어져서 그게 너무 무섭고 그러고 나서 다시 또 괜찮아지기까지도 좀 아프고 근데 순간 속에 정말 스쳐 지나가듯이 뚜둑 약간 이런 느낌이에요. 그냥 걷다가 빠지는 거는 좀 덜 아픈데 뛰다가 빠지면 훨씬 더 아프고 약간 고통의 그 기간도 차이가 좀 많이 나더라고요.
So this is one of very typical symptom of patella dislocation. Some patient felt very severe pain and the prominent clunk when the patella is dislocated, and some patient sometimes if the soft tissue is very soft, the patient cannot really recognize the dislocation. Anyways, when the patella is dislocated, almost all patients felt some degrees of instability and the loss of the power suddenly kind of giving away. Let me show you the x-ray. She was 29 years old female. Her first patella dislocation occurred when she was in high school. After that, countless times of dislocation happened. And recently, she experienced very severe pain with dislocation. When you see the x-ray of a whole lower extremity, you can see a mild degrees of genovarum, bow legs, and bow legs itself is not a risk factor for patella dislocation. And this is normal patellofemoral joint. This is the femur, the femoral groove, and this is patella. This is normal position. And this is patient's patellofemoral joint. This is the femur, the shallow femoral groove. The shallow femoral groove means that her patella was not in a proper position from she was very young. So the femoral groove could not develop with growth because patella was not in this position. Anyways, patella was almost subluxated in both. This is right side and this is left side. Right is more severe than left. And left side is not that good. And when you see the x-ray from the anterior to posterior femoral bone is rotated, that means rotational torsional deformity of the femur. Left side we can also dislike. So from the plain x-ray we can see this patient has torsional deformity of femoral bone. I performed physical examination and apprehension test was positive. Apprehension test is kind of a provocation test, and the range of motion of hip and thigh foot angle shows she has torsional rotational deformity of the femur and tibia simultaneously. With this condition we can say she has rotational malalignment syndrome. So I checked the CT scan to find the exact amount of torsional deformity, and I checked femoral torsion was 30 degrees and tibia torsion was 30 degrees and TTTG distance was 20 millimeters. It's all out of normal range. TTTG distance means that tibia tubercle trochlear groove distance. Trochlear groove is here and tibia tuberosity is here. If this distance gets farther, the patella tendon tends to pull the patella lateral side. So this is the large amount of TTTG distance is one of the risk factors of patella dislocation. When you see the CT scan on the left side, also trochlear groove is here and tibia tubercle is here. So you can see the large TTTG distance. This is the knee joint, femur, and this is tibia, and this is patella, kneecap. When you bend the knee, patella gets into the femoral groove, trochlear groove. This is the normal articulation of femoral patella joint, like this. Like this. When we say patella is dislocated, usually patella goes outside like this. This is patella dislocation. If there is some contact between the femoral patella joint, we can say this is patellofemoral subluxation. So how rotational malalignment syndrome affect this joint? If the patient has rotational malalignment syndrome, even though patella is positioned like this properly, underlying femoral tibial bone goes like this, rotate. This is rotational malalignment syndrome. So patella tend to go outside just by the shape of the bone. If the patient has this kind of deformity, if we do not correct this deformity, we only pull the patella medial side like this. After surgery, in the short term, it will be positioned properly, but in the long term, it will go outside. This is recurrence because underlying deformity is not corrected. If the patient has this kind of deformity, the most important and the most fundamental treatment is correct the underlying ground like this. So if we correct this deformity properly, in my experience, we do not need medial patellofemoral ligament reconstruction, almost to 100%. We can say the current status as underlying deformities for recurrent patella dislocation. First is rotational malalignment syndrome, and second is abnormal increased TTTG distance. And many patients has genovalgum, knee. Knee is also one of risk factors of patella dislocation, but in this case, she does not have this condition. So my treatment plan was correction of bony deformities as a first step. And if patella dislocation recurs, I will do MPFL reconstruction, ligament reconstruction. But as a first step, I only correct these bony deformities and soft tissue release without ligament reconstruction. I will show you the video in the OR. This is pre-op and this is post-op. This is very interesting video how rotational malalignment works. This is pre-op. Can you see? When I dorsiflex the ankle, knee joint rotate inward. This is one of phenomena observed in rotational malalignment syndrome patient. And this is after surgery. Same maneuver. You can see knee joint does not rotate. You can compare simultaneously. The before surgery, the after correction of rotational malalignment syndrome. And this is patella dislocation. I used my thumb to provoke the dislocation. This is patella. Can you see? This is patella. Easily dislocated with my thumb power. Okay? And after surgery, I push the patella with the maximum power of my thumb, but patella does not dislocate. It's very stable. You can compare. Very, very stable. Even without ligament reconstruction, only by the correction of the bony deformities. So here's the X-ray before surgery and after surgery. I also corrected the genovalgum. The position of patella is located in proper position after surgery. I didn't do ligament reconstruction. This change of position is done only by the correction of her background bony deformities. And before surgery and after surgery, on the right side, you can see the patella faced inward, and after surgery, patella face forward. This is the photograph from the lateral side. The kind of big surgery, but is done by minimal invasive and minimal incision surgery. I want to emphasize again, most of the recurrent patella dislocation cases has underlying bony deformities. In those situations, the correction of those deformities is most important and fundamental treatment, and that enables the lowest risk of recurrence. Without this correction, only ligament reconstruction tend to the recurrence of patella dislocation in the long term. If we correct this deformity properly, patients feel very, very comfortable. This feeling is different from just pulling the patella by ligament reconstruction. We will upload the whole interview of the patient next time.